standard ceramic used today, it is highly resistant to wear. And the reason for that is that this is the structure of the ceramic crystals, and then you have the zirconia in between. So it prevents these intramolecular cracks from disseminating. Then you have plate crystals. So this is a very, very tough ceramic material. And this has addressed the problem of its ceramics, which was its brittleness and tendency to fracture. Now with the insertion of all these crystals, these are very, very resistant materials. Then of course, this is the wear rate. As you can see, metal on metal is ceramic on metal. Of course, we don't do that anymore. Ceramic on ceramic is the minimum wear. So this is the wear-wise is the minimum. But there are problems with ceramic. The concerns are with the fracture risk. It could break, and then you have. It's more, of course, in the acetabular component. The other problem is sensitive to cup position. So if your cup is not exact, then you have transfer here. Ceramic chipping can happen, and you can have metal transfer to the ceramic, which causes strike wear. Squeaking is a problem, which is a noise which emanates on ceramic bearings. So ceramic on highly cross-linked is, I think, the way to go today. It is more forgiving to errors of alignment. There is a significantly lower volume of wear. There is no problem of chipping and squeaking. Excellent long-term survivorship. So highly cross-linked liner allows the use of larger metal heads. It gives more stable hips, and it reduces the incidence of dislocations. So if you have if we can make an algorithm, less than 40 years, you could still use ceramic on ceramic. Although people are still moving away from this, they're moving to this. 40 to 60 ceramic on highly cross-linked poly, and more than 60, you can still use the metal on highly cross-linked poly, because that is significantly cheaper. What about the osseointegration? The ingrowth of bone trabeculae onto the surface results in a permanent incorporation of the metal implant, and therefore the incidence of loosening is greatly reduced. The larger femoral head, 32 or 36, gives better kinematics, decreased dislocation, and allows cross-leg sitting and increased activity. Modularity, this is particularly useful in congenital situations such as the DDH, where you have a separate sleeve for a metaphyseal fixation, such as in this implant, and you have a version modularity where you can actually rotate this to correct, to match, or to correct the version abnormalities, and is particularly useful in DDH. So just a study which we did in our hospital, 341 cases which were looked at, 29 to 50 years. More were males, severe gait disturbance, significant pain, 1 to 8 years follow-up, and the commonest causes were avian and ankylosing spondylitis. This was a study I'd like to present. The cementless hips were done, tapered HA-coated stem. The femoral head side was a large head. Acetabular augmentation had to be done in a lot of cases. The bearing surface was ceramic on highly cross-linked polyethylene, and the posterior approach was used. Some examples: this is a vascular necrosis, where we have used a ceramic on poly, this was ceramic on ceramic, and a tapered apatite-coated stem. This is ankylosing spondylitis, very common in our country, fused hip here. This hip is again advanced arthritis. This is a post-operative X-ray using a ceramic on poly. This is another example of bilateral rheumatoid in a young patient, and after the surgery with a large head, he is able to sit in this fashion. And he is actually a carpet maker, so he's back to his profession. Non-union fracture neck femur. Again, in a young patient, requires surgery, ceramic on poly with a non-cemented apatite-coated stem. This was a femoral head fracture, again done with a ceramic on poly. Here we had to use a cemented socket because it was a very, very small female patient. This is a neglected fracture dislocation, 9-month-old fracture dislocation of the hip, with the patient hardly able to walk, and intraoperatively large posterior superior defect. The femoral head was used to reconstruct the defect, fixed with screws, a non-cemented socket, and a large femoral head. Untreated DDH, this is a Crow type 3, and here we had to use the S-ROM stem. This is the sleeve, which gives us metaphyseal fixation, a version modular stem with a pronged stem here to achieve distal fixation. This patient had the version had to be corrected. Most of them are excessively anteverted. Now, a lot of the time, these CDH patients have previous surgeries, and these can cause a lot of difficulty, again, treated with modular stems. So these are strategies that you have to adopt in these young patients. They are hardly 24 or 25. Neglected Perthes disease, again, uh, with the same strategy. This is the outcome. So all patients were able to walk with a walker support on the first post-operative day. Most patients were ambulant without walking aid 3 months after surgery. All patients satisfactory pain relief. Ankylosing spondylitis patients were slow to recover and had a problem because the spine was affected. Complications included few cases of dislocation, 1 case of fracture, 4 cases of infection, 37 cases of loss to follow-up. There were no cases of implant loosening. All patients rehabilitated well. So this was the control study in 137 patients. This I think we'll go through this quickly. So in conclusions, ceramic on cross-linked polyethylene surface is the way to go. Femoral head size 34, 32 or 36. Cementless porocoat or HA-coated stem, socket and stem, bone-sparing stems where possible. Femoral modular stems where indicated, bone graft to restore defects, and a longer follow-up, of course, to establish. So these are the strategies for planning THR in young patients. And I thank you for a patient hearing.
Thank you, Dr. Chen. Questions from the audience? Okay, any questions from here? Okay, in that case, thank you, Gurudev. It was great. And I think we got a lot of insight into a difficult topic. This is a problem. Replacing hips in the younger population is a problem. Now, we will take just a 5-minute tea break. Please have some tea, and then Ravi is going to speak to us about wrist fractures and tendinopathies. Now, Ravi is basically a hand and wrist surgeon. So you will get a chance to listen to some subspecialty talk, because normally in a general orthopedic platform, you will not hear these talks. So there are lots of new radial plates and lots of new things. So please wait until we just have a 5-minute tea break.
petto era quello, non sai dare, lo che morto, se si fa di This one, what did you type strip is only for 75 I think it's more cheap with the big. Can I guess one out? Can I guess one out? What did you get?
please call the doctors inside. This is going to be quite an interesting topic, wrist fractures. I'm sure you have not, wrist fractures are quite common, but you don't see these new things very often, so please do come in. Mr. Chokalingam, can you put the first set of slides on for Ravi? Ravi is in Apollo. He's a consultant orthopedic and hand surgeon, and he is going to show us current ways of treating wrist, hand and finger injuries and and also I think you have non-injuries also, right? Yeah, so I think it'll be quite a comprehensive approach to hand and wrist fractures.
Good evening, and thank you very much, Dr. Banerjee and the organizers for this opportunity. It's indeed an honor and a privilege. My brief is to talk on hand and wrist fractures, and because I see that the majority of you here in the audience are PG trainees, this is unfortunately a very neglected part of the orthopedic curriculum at the PG level, simply because there are so many more important things you have to learn about, like hip fractures, spine, and other pathologies. So basically, hand fractures, wrist and all are delegated to maybe one or two short notes in your exams, and but when you come to the real world, you realize that how ill prepared you are, because these take a significant part of your orthopedic table practice when you start practicing, and then you are at a loss because you don't know how to deal with them properly, because it was never given the due importance. It's not possible to cover everything in 3 years. Similarly, in the next half an hour, it's not possible for me to cover everything related to hand surgery. About hand surgery, there's a very famous quote by an erstwhile American hand surgeon by the name of Alfred Swanson, and he used to say, hand surgeries are often complicated by deformity from no treatment, stiffness from over treatment, and both stiffness and deformity by poor treatment. So we have to try and strictly avoid not to follow into either of those categories and try and give the best to our patients. So on that note, I'll start with my first slide. Okay. I'll make it a little bit interesting for you, because you had a tea break, you had a long 2-3 hours of intense academics, so I'll like to liven it up. I'll ask you a little bit of questions. So this is a scenario where it's a 32-year-old cricketer who dived to save a boundary and injured his right index finger. You see, with the IPL season, everyone's diving to save boundaries. Got an injury there, and there I give you his X-ray, and then I ask you, what do you see? So would anybody like to volunteer? What do you see? Right index finger? Palish? You're struggling, isn't it? Anyway, the question you should ask yourself is, what don't you see? Because I won't hazard a guess on that X-ray. So the point I'm trying to make is, if you're trying to make a guess of what is a possible fracture based on a poor quality X-ray, don't accept the X-ray, get a correct X-ray view, otherwise you will miss the diagnosis. So this is a bony mallet finger, which was missed because the proper X-ray wasn't taken. And when we have a proper X-ray, then this fracture becomes very obvious. But if you had gone by the first X-ray, you would have said probably there is no bony injury, given him some aceclofenac and some anti-inflammatories and some ice, and said go home, and then he would have been left with a deformity, and which would have been picked up a few weeks later, and then he would have had a bad deformity which would have been career threatening, and you would have been left with a red face and maybe even a lawsuit. Okay. So that's the fracture which was treated by extension ball planing. Once you know the diagnosis, then the treatment becomes very easy. It's just a couple of carefully placed K wires, and that's back in position, and that's a satisfactory healing achieved in a few weeks' time. Okay. So this is called the Ishiguro technique of K wire fixation for bony mallet finger injury. So the point I'm trying to make with that case example is that the correct views are mandatory to make a diagnosis. So if you don't diagnose properly, forget about treatment. How will you know? You need to know what the problem you're dealing with. So the mantra for any finger injury is get a PA and a lateral view of the concerned finger. Please do not X-ray the entire hand. Okay, so same fracture, see. If you X-ray, if it's an index finger injury and you have palpated, you have clinically examined, there's no other injury elsewhere. Get an X-ray of the finger. Why do you want to do the whole hand? Because the whole hand will be an oblique view and you will often miss the injury. But if you get a PA and a true lateral, a subtle injury like here, like there's a fracture here, and if you get a true lateral, you see dorsal subluxation here, which is often missed, a PIP joint. Okay, so if there is more than one finger involved, then you can get what is called a splay lateral view. Multiple lateral views on one film. This is called a splay lateral view. Okay, so finger injuries, correct information is PA and true lateral views. Okay, what next? The same fracture. You saw the injury. Okay, dorsal subluxation of the PIP joint. I give you an MCQ option. Are you going to do a MUA and splint the finger in extension? MUA and splint the finger in flexion? Are you going to neighbor strap it just for 3 weeks, or going to neighbor strap it and start early mobilization? Again, I've got 4 options. What do you want to do? Very common. What do you do? See, the normal method of treatment for any immobilization we have been taught is the safe position of immobilization, where we keep the wrist in about 30-degree dorsiflexion. The MCP joint is kept flexed, the IP joints is kept extended. This is the safe position of immobilization, because even if the hand becomes stiff in this function, with the MCP joint flexed, with rehab you can get this movement back, so you will get useful function quickly. That is the classical teaching. In this case, it's an example which is slightly different, that's why I chose this. The correct answer, I'll put you out of your agony, is you have to do an MUA and splint this in flexion, not in extension. And the reason why, because if you look at this is a fracture here, this is proximal phalanx, this is middle phalanx. This is an avulsion fracture with the, it's a small fragment here, but the volar plate is attached here, and the collateral ligaments are attached here, so this fragment will tend to go upwards. So there is a dorsal subluxation, okay? So if it's a dorsal subluxation and given the shape of this, like a femoral distal femur, like a cam, it will be stable if you flex the finger. So you have to give a dorsal blocking splint in flexion, and that is the correct way to treat this injury. Okay, not splinting in extension. Okay, this is another case. I get a lot of finger injuries from wannabe cricketers with the IPL and trying to get into IPL, second division, first division, all sorts of divisions. So this is a female cricketer inspired by Jhulan Goswami, 29-year-old, right index finger. Okay, she had a burst laceration on the finger. So that wasn't just a skin burst, nothing more. But then this is what we did. So we did a close manipulation. I won't go to the videos. So basically we just hyper exaggerated it to get the volar plate out, and we flexed it. Now the joint is reduced. Okay. Now this has been reduced under ring block. I give you the post reduction X-ray, and you have 2 options, correct or wrong. Indrashis, acceptable? No. Why? Because the slide is there and I'm asking you the question, that's why. Okay, tell me why it's not wrong. Because it has not been reduced properly. You see this is called the V sign. This is wrong because there is still persisting dorsal subluxation. This is not a congruent reduction. This needs to come down a little bit more. So that is why this is not acceptable, and if the joint is immobilized in this way, it's invariably going to get stiff. Then you very commonly see the splints applied in OPD, and you have probably prescribed these kind of splits also because you don't have a knowledge of splint. And when you see a finger injury, you have reduced it, done a good reduction, and then applied a splint like this. Right or wrong? Wrong. That's why it is there. Okay, otherwise it won't be here and I won't be talking. Okay, so basically this finger dislocates in extension and it's stable in flexion. So what should be the splint? Should be a dorsal blocking splint with the finger in flexion. You can use any malleable aluminum splint. be anything fancy. You can just use micropore tape or any tape you have, like this. This is the same finger. I bent them aluminum with some padding here, and this is the joint nicely reduced. And this is how it looks like. This is the correct way of immobilization. And you see, you have taping here, and the finger is bent like this. Okay, so you see the reduction here. The advantage is you can get the actually patient to start bending the finger straight away. So it's a dynamic spin. You can finger is mobilized, but it can't extend. So because it can't extend, the dislocation is not happening. The joint is kept in a stable position, but yet you're allowing active movement. So stiffness chance is less. So this is the way you should proceed. And this is her when the splint was removed. It's just at 3 weeks. With another couple of weeks of physiotherapy, she will regain full range of movement. So it's very important to pick up these and treat them correctly. Okay. So this is another case. Dr. Banerjee wanted me to include a wrist arthroscopy case. So this is a very interesting case. This is a side of ulnar-sided wrist pain in a sports person. He plays badminton, but it also happens to be a lawyer. Not that he meant it in a threatening sort of way, but just I'm mentioning it in passing. 21-year-old law student, right-handed, was playing badminton, twisted his right wrist and came with ulnar-sided wrist pain. And this, he had something what is called a, you must have heard this, positive piano key sign. When you press the head of the ulna, it goes down. When you leave it, it just goes up and down, just like a piano key. When you press it down, it goes down and then it comes up, like a springy feel. Okay, it's called a positive piano key sign. That is a sign of DRUJ disruption. The ligaments which connect the distal radius to the ulna is disrupted. That is why you call it ballotment or a positive piano key sign. Okay, so this is what the patient had. These were his x-rays, and you know, in the x-ray there's nothing unusual about it. But when we did an MRI, because once you don't get, you know, it's a player, you have to have a low threshold to diagnose this. And clinical examination is everything. If you feel that there is instability of the DRUJ and there is tenderness over the triangular fibrocartilage, okay, you have a low threshold to get an MRI, because an X-ray is not going to tell you anything, and you're just delaying time. If it's a high demand patient like a sports person, all the more reason to get the MRI early. Okay, so this is what we got, and if you see here, there is a signal intensity and there is a tear there. It's a triangular fibrocartilage tear. Okay, so this is called a foveal avulsion, and you see how bad it was, because you know he would not allow us to examine properly because of the pain. But once he had a brachial block and we took him to operate in the theater, you can see the proper examination. You see this, how unstable this is. Okay, badminton, he's not going to be a very good player if we leave him like that, no? So what we should do? Open surgery. This used to be done in the past, so we are talking about some recent advances. Now we can treat this with arthroscopic surgery. This is a DRUJ instability. Now before that, I want you to understand a couple of concepts about the DRUJ. Earlier, you know, refer to this. This was thought to be the, you know, this is the ulnar styloid, and this was the triangular fibrocartilage. It was thought like it's a hammock which is suspended on one side to the sigmoid notch of the radius, and then the other side was to the tip of the ulna. So Professor Toshi Nakamura of Japan, he gave this concept. We still see him as a very senior guy who comes to hand conferences. So this was called the hammock concept of triangular fibrocartilage. But my good friend now is from Italy, is a guy called Andrea Adzi. And that is his classification, a very brilliant arthroscopic surgeon from Italy. He has given us this concept. It's called the iceberg concept, in which they think about the TFCC in two layers. There is a deep layer which attaches to the foveal region, and there is a superficial layer which attaches to the tip of the styloid. And it is this deep layer which is the main stabilizer of the DRUJ or the distal radioulnar joint. And if this is torn, this is what leads to that cross instability. Okay, so we have to repair the TFCC back to the fovea. So we have to make sure, like, the foveal attachment is restored. And now, thanks to some sophisticated instrumentation and arthroscopy guides, we can do it arthroscopically. Earlier, you have to make a big incision. Now, how many of you have seen ACL surgery? Arthroscopic ACL reconstruction, most of you have seen. So it's a similar principle in miniature. Okay. So this is the foveal attachment. Okay. This is where the tear was. So we are trying to attach this whole black thing back to this part of the ulna. So how do you do it? So there's many techniques, but the most important thing is isometry. Just like in ACL, isometry is important. You have to reach that footprint of the ACL, you have to reattach it here. Here also the same thing. So we use something called a TFCC jig. This is a specialized jig. And and you see this tip is kept here. This directs the K wire to come out just in the foveal region. This is my arthroscope looking into the joint, and this is the close-up of the jig placement, and this is how we drill a sort of a guide wire into it, and over which you use a cannulated drill bit to drill a ulnar tunnel. Okay, so once you drill the ulnar tunnel, this is where the sort of I'm not showing you the details just to give you a flavor. So this is how, once the repair has been done, you have to use two sutures, and now this is the TFCC which has been repaired to the foveal region. You see a little bit of tenderness over the end, synovitis where the injury was. So this is the TFCC which has been repaired, and this is the same person. 1 year follow-up, able to do all the movements: radial deviation, ulnar deviation, upwards, downwards, palmar flexion, dorsiflexion, circumflexion, everything is okay, and he has regained full power. So all that done, if you look at his incision, just 2 stab incisions in the back of the wrist. Okay, so it's possible to do this arthroscopically. Okay. Now I'll come to distal radius fractures. I have not got time to cover all the fractures, but distal radius forms a very important component and one of the most common fractures which you deal with in trauma. So just like next to probably femoral neck fractures, distal radius is probably in the upper limb the commonest fracture you'll deal with. And most of you need to have a very good understanding. So we'll talk about some basic concepts and then some case examples. Okay. First of all, you have to understand that all of you say something very commonly at a Colles fracture. I've seen a Colles fracture in emergency, and you try and not use these eponyms because we don't talk about these eponyms. So what is actually strictly a Colles fracture has to fit in certain criteria in a particular age group. So the first thing to appreciate is distal radius fractures comprised of a broad spectrum of injuries. So the same injury in my mother would be very different from happening to me, would be very different from what's happening to you in a child. It's all same. All are distal radius, but all behave differently. So they can range from simple fractures to complex fracture dislocations. That is the first thing to apply, to appreciate. It's a very heterogeneous group of injuries. The demographics, almost 17.5% of all fractures in adults, more common in females, 2:1 ratio, and there's a bimodal distribution. That is what I want to understand. Bimodal, what I mean, which means there is a group which happens in young patients like road traffic accident, motorcycle accident, fall from height, sports injury. These are high energy mechanisms of injuries versus older patients, geriatric patients, fell in the bathroom, fell while, tripped over her own sari, tripped over her own, carpet, fell in the house, ground level fall, low energy fall on outstretched hand. These are typically people who have osteoporosis pre-existing. So it doesn't take too much energy to fracture a weak bone already. Okay, so these subsets of patients completely different. You tend to be very aggressive in the younger patients because they tend to be more intra-articular fractures and their restoration of anatomy is paramount. Otherwise, you will not get full function. In the elderly group, functional demand is less, osteoporotic bone, mostly they tend to be extra-articular, a little bit of malunion, a little bit of collapse really doesn't going to affect the function. So you're not going to think about fancy plates and restoring anatomy. Okay, this is the principal difference I want you to understand. Young patients, high energy injuries, older patients, osteoporotic bone, extra-articular, low energy injuries, completely different subset of patients. So mechanism injury you all know. Don't forget other associated injuries. You could miss associated scaphoid fracture. Sometimes both can happen along with the distal radius fracture. You could have an undisplaced scaphoid fracture. You could have a widening of the scapholunate interval, a scapholunate ligament injury. You could have an associated triangular fibrocartilage tear, like that ballotment with the fracture. And I tell you how to do it. And the patient could be complaining of median nerve symptoms because of the tenting of the dorsally the fragment has gone, the sharp anterior fragment. Just like in a supracondylar you have a brachial artery and the median nerve compression. Similarly, rarely in distal radius in displaced fractures with significant angulation you could get median nerve neuropraxia. You have to check specifically for that. Now, Rickley and Regazzoni gave us this 3-column concept. I'll touch very briefly. So basically, they say this part on the radial column is where the scaphoid articulates, and this is responsible for stability of the radiocarpal joint. The lunate fossa, this light green colored thing, it transmits the compressive load, and the TFCC with the head of the ulna, that is responsible for DRUJ stability. Okay, this is a very important concept. So when you do your fixation, you have to think in terms of, have I fixed the radius column stably? Have I got the intermediate column alignment correctly? Have I restored the stability of the DRUJ? So you have to think in terms, like in tibia now we are thinking of column concepts, yeah? The modern column concept of tibial plateau fractures. Earlier it was Schatzker, now it's the column concept. So similarly in distal radius, column concept. Okay. So this was when X-rays were being used. Now we are using CT scan, so things are even more complicated. So we have a CT scan based 4-corner concept. I'll touch very briefly because you might get this as a short note in your MS or your DNB exam. Not very much detail, just the basic concept. So basically there are 4 concepts: the radial, the ulnar, and the intermediate column has a dorsal and a volar. So 4 corners. Okay, each has a separate function. Each can be involved in any sort of permutation combination, and it is important to restore all. So this is a concept called the key corner concept, where you do a CT scan of the intermediate column and see the position. So basically I'll give you an example. This is dorsal, this is volar, this is the distal radius profile, this is the lunate. Yeah. So has the lunate gone volarly or dorsally? Yeah. More volar, correct? So the key corner is the volar, so you would approach this with a volar approach. How do you know whether to put a dorsal plate or a volar plate? Not just because I feel like doing it. There are certain principles. So this is what. So you have to see whether the lunate has subluxed dorsally or volarly. That would determine the approach, because that is the key corner that needs to be fixed. Look at this example. So much of comminution, okay? Where has the lunate gone?
Dorsal.
This would probably be a case for a dorsal plating, if not for a bilateral plating, okay, for both dorsal and volar. So this is how you make a diagnosis. You have to determine the key corner and then fix it, okay? Okay, management will determine upon various factors like patient factors. You just don't see the X-ray and treat it. Patient, everyone has a different activity level. What is a sedentary worker, low exam, maybe already having rheumatoid arthritis, maybe already having hand problems, might not be very high functional demand. You're not going to put an expensive plate to restore the anatomy because the pre-existing hand function might be poor. Okay. The fracture pattern, high energy or low energy, whether it's stable, associated injuries. So all this. The important question is, think rationally, ask your patients. These are the things you need to ask, whether it's displaced, undisplaced, intra or extraarticular, reducible, irreducible, stable, unstable. Based on this, you make your decision. Okay. Do you know which are the unstable fractures? How do you determine? This is again another short note which might, this is a very important sort of criteria for stability. How do you know which distal radius fractures are stable, which are unstable? So again, very briefly, if there's advanced stage in osteoporosis, if there is significant comminution, if there's metaphyseal comminution, if there's intra-articular comminution, or if the displacement is more than 20 degrees dorsal or translation more than 10 millimeters with significant shortening, or if there's associated distal ulnar fracture, these are unstable fractures. This has been given to us by M. Lafontaine in Injury 1989, old paper. Okay. And this is the criteria for acceptable reduction. You know, whatever be the method of fixation, it could be a simple MUA with cast, you could put K-wires, you could put X-fix, you could put JES, you could put dorsal plate, volar plate, whatever fancy plate, you have to try and restore these anatomical parameters. Radial height should be less than, this must be the, these are the values. I'll read it up, I won't read up. So these are the acceptable parameters for a reduction, okay? Treatment modalities I have mentioned, there are multiple treatment modalities. So you have to decide what is the best for this particular patient, depending upon the patient's functional demand, the personality of the fracture, and your own ability. If you have never done a dorsal plating before, it's not a good idea to start off thinking, let's do this, because you have to have a little bit of training and exposure before you try a new modality, okay? So, there's plenty of plates available, like Dr. Banerjee was mentioning, but the basic principles of AO is anatomical reduction, stable fixation, and early mobilization. In the interest of time, I'm not going to plaster, I'm not going to K-wire, X-fix, I'm straight away only talking about the plate fixation. Not all of them require plate fixation, but because the time is limited, I will talk to you about some tips and tricks about plate fixation, okay? 3 mantras again. You plan, you prepare, and then you perform. So if you don't write out your operative plan, you can't make it up as you go. You have to have a clear idea. This is the X-ray, these are the implants I need. This is what my approach is going to be, and this is what I want to do. So you have to have a clear plan in your mind before you enter the theater, okay? Then you prepare, you order the inventory, you say whatever, additional imaging you need, any CT scan, any on-table traction use, whatever. And then you execute your plan. This is how you go about it. Any fracture, not only wrist fractures, I think for any trauma case, any elective case, whatever you do, these are the mantras. So you should know your patient and the functional demands, you should know your fracture pattern, You should know your implants. Every implant has some certain design characteristic you should be aware of. The standard, most common approach is the volar Henry approach, which you're all familiar with, I'm sure. So what I tend to do, and I think it's a good idea when you're starting off, try and, even if you don't have fancy marker pen with betadine, you mark out the FCR, this. And when you cross the wrist crease in distal fractures, make a little zigzag here so that it's not a vertical, because the little bit of contracture will give you a little bit of limitation of movement. So if you cross it in an oblique sort of zigzag fashion, you're less likely to get a wrist contracture at the wrist. Okay. So once you do that, before that, have you seen this? This is where I palpate the radial pulse and always mark it so that I don't nick it by mistake. Sometimes you could get some anatomical anomaly and the artery is a little bit more medial than you want, and you don't want it just under your knife incision. So it's always a good idea to palpate the pulse, mark it, and then mark your incision line. Next, ergonomics, very important. Be seated with good lighting, good visualization. Once you reduce your K-wire fracture, you try and fix it provisionally with K-wires. It always helps. And then, as I said, mark the pulse and the incision. The standard volar approach. Now, provisional fixation with K-wires, I always try and do that. If you can reduce the fracture to an acceptable alignment, fix it usually with a radial styloid and a dorsal lunate wire. So that's the fracture which is looking so bad on CT scan. You think, what the hell am I going to do with so many fragments? But once you pulled it out to length and reduced it, you see it comes back nicely into place. And this is just sort of 2 or 3 K wires, and this is the radius. And what I have done is just put the plate on, and after the fixation is done, you can take out the K wires. So K wires are very good as a provisional reduction tool. Okay, so that's it. Now, sometimes this is a little bit technical, but these are some tips and tricks in volar locking plate. Not all of you might be requiring it, but you get this scenario. If you look very carefully, you think that this is just shortening here and this I'll pull it out to length. But you notice this bump here. If you don't sort of reduce this little bit bump, it might seem like nothing too much, but then this patient is going to get DRUJ arthritis because the sigmoid notch is not going to be congruent. That patient will recover this movement very nicely, but whenever it's pronation supination, this bit of irregularity is going to give trouble. So how do you reduce that? So I'll just give you a very simple trick. Pull it out to length, and then you pass something called a Kapanji wire, which is simply but a K wire which you drive into the dorsal fracture site through the skin, just like this, under C-arm guidance. Guide it into the fracture site, lever it downwards and push it into opposite cortex. So what happens as a result is, this articular congruity, this dorsal sort of tilt is corrected, and you regain the normal palmar tilt. You drive this K wire into the dorsal cortex. Once this pin is placed, you push the sigmoid notch against the push the head of the ulna against the sigmoid notch. You just apply pressure on the styloid on both sides like this. This will push the fragment like this. The fragment cannot go dorsally because the K wire is holding it, so it will just naturally mold itself into its anatomical configuration. Very simple way. Just pressure on the ulnar head. See this, how nicely it sits. I have done that. Look at this irregularity. Now see this. It's been corrected. See this here. See this here. All that was required is by thumb applying pressure. Simple, but very effective. This patient will no longer have problems with pronation supination because it took me an extra 2 seconds to apply that pressure. Okay, but if you didn't know it, you won't do it. You would think you would have a good looking X-ray and you would be wondering why your patient is having pain on pronation supination. This is a small tip and trick, never written in any textbook. 25 years of experience, that's what I learned. Okay, more technical tips. The pronator quadratus is erased very carefully in an L-shaped manner. So you see this here. Now you see I am applying 4 Langenbeck retractors. Okay. Now the placement of the Hohmann lever is very, very important because I'll show you why. If you see Hohmann retractors normally which we get in a set, in a standard set, there were 2. One is this wide one and one is the narrow one. Okay. Always place the wide one radially but the narrow one ulnarly. I'll tell you why. Because what happens is, you have an intraosseous membrane on the ulnar side. If you are jabbing a wide, Hohmann retractor into the intraosseous membrane, you're just damaging that much. That will heal over a period of time. You will never see that injury with your naked eye or on an X-ray. But you will see that these patients will always take a longer time to recover the pronation and supination. So if you can instead use retractors to retract the ulnar corner, you will always get a easier, better return of function. and your weeks of physiotherapy will be reduced by at least 2 weeks lesser physiotherapy to regain full range of motion if you are just careful with the soft tissue. Okay, so this is what I tend to use more. This avoids intraosseous membrane, so use these retractors rather than jabbing a Homan into the intraosseous space. If you see this very carefully, I have placed the wide one on the radial side and only the tip of that in the ulnar side, and this is the plate in place, and I am doing the ulnarmost screw. This is where you need the visualization of the ulnar corner. Okay. So if you have a radial styloid fragment, you will wonder that you are not getting a perfect reduction. Why? Because there is a muscle and a tendon attached to it. It's the brachioradialis which inserts into the styloid. So unless you erase the brachioradialis fully, you will never be able to, because the brachioradialis, the other name for the brachioradialis is the supinator longus. Okay. So it will always tend to supinate the fragment. So if you want to get a perfect reduction of a radial styloid fragment, if you're not getting it by traction, don't hesitate to extend the incision and slightly erase the brachioradialis insertion. So if you do that, see this fragment here. You can pull it and you will still think that there is a step here. But if you just go a little bit distal with retraction, with careful, all the radial artery and everything out of the way, subperiosteally with a 15 blade, just release the brachioradialis. You get a perfect reduction of the styloid fragment. You can't even tell that the fragment is broken. Same from here, let's come to here. You have fixed it with 2 provisional K wires. Now it is just like plating an intact radius. Just put your plate on, then take your K wires out. Simple. Okay. So now the plate, usually you put a oval hole, you put a screw and you move it up and down to see, where it is with respect to the distal radius. Now you should know your implant. Most of the variable angle plates, there are various designs. Somehow these holes you should know. You put a cortical screw through the oval hole first, like this, in the center. Then you have the option of moving the plate up and down. If you want it closer to the articular surface, if you put the screw here, you can move it down. Or if you want it too close, you want to lift it up, okay. So in this oval hole, if you put it in the center, you have the option of moving the plate up and down. So use that feature of that combi hole, okay. And then you can move it as distally as possible. Most of the time you use one cortical screw to compress the plate to the bone like this, especially in a volar button fracture. This might be too long, but once you put the 2 locking screws at the top, you can remove this and substitute it by an appropriate length screw. Otherwise it will cause tendon irritation, okay. So this is how it was done. The other thing, whenever you put your styloid screw, you will think that the styloid screw is intra-articular. That's because of the normal radial inclination of the distal radius. So if you think like this, you actually have to do a true lateral view, which means you have to lift the forearm about 20 degrees. So 20 degrees is the normal radial inclination. If you lift the forearm, then the same screw which looks like it's inside the joint now suddenly looks intra-articular. So the correct way of taking a lateral view is not dead lateral like this. You lift it about 20 degrees and then you take a lateral view. Then you put a styloid screw. Then you will know the length of the screw is correct. Okay. Okay. I'm sorry. No, online audience. Okay. So the other thing you have to, how do you decide the length of the screw? We usually put a screw and you measure with a depth gauge, but then you sometimes think that you've got the right thing. Now it might look like it is short of the dorsal cortex. Here you see this is the plate and you think your screw is of the sufficient length because it has not breached the dorsal cortex. So would you be happy with this length of screw? But there is a small pitfall. See, the shape of the distal radius is like this. Because of the Lister's tubercle like this, okay, your screw could actually be exiting here, but on the lateral view, it will seem like it is inside the bone because the Lister's tubercle is projecting higher. So what I'm trying to say is, your screw could be sticking out through this like this, and you could still think that it is in the bone because this is the region of the Lister's tubercle here, but your screw tip could be coming here, and it could be irritating the extensor tendon here. And after a few months, you would see the thumb is not moving because it has caused attrition rupture of the EPL tendon. Can happen. Sometimes happens. It's iatrogenic. So what you do is you stay well clear. At least 4 millimeters, 3 millimeters, 4 millimeters of dorsal cortex. You take this into account and keep your screw sufficiently short. If it's a locking screw, it doesn't necessarily have to touch the second cortex. Unicortical purchase is enough. So the role of special views, these are special views called carpal tunnel views. So you don't know whether your screws have touched the dorsal cortex, but if you do this, if your fixation is stable, you can take a carpal shoot through view and you can see that all the screws are intra-articular. This is the way of checking whether your screws are too long or too short or they are just right. Okay, these are special views which you can do fluoroscopically on CM if you are sufficiently happy that your fixation is stable. Okay. Okay, very distal fractures, again some tips. This is called a rim plate which extends beyond the watershed line, and you can take bites through the capsule and stitch it to the holes in the plate. So this is what is being done, and this is for rim fractures of the distal radius. Sometimes you feel that you don't have a rim plate and you still have a very distal fracture, you're not prepared. Don't lose hope. You can put a small screw like this separately distal to the plate to hold this fragment. So I've done that because I had a small cortical screw. If you still don't have that, you have a K-wire. Always every OT K-wire is available. This is another bailout. This is a very distal fracture. I didn't have a rim plate. I didn't have a CT scan. Patient could not afford. Now, what I have done is you take a K-wire and bend it like this, just like a plate, like a L-shaped, okay, double. And you place it under the plate. So this is the implant like this, just a bent K-wire. I happen to have a titanium wire because I was using a titanium plate. You can do it with stainless steel, no problem. So bend this. And you see this is the wire under the plate extending distally. On top of that, I've just used the plate to push it down. So you have a distal fixation, 2 prongs with the K-wire which I've drilled. So it's just using your common sense and a little bit of Indian ingenuity, okay. So there is a separate segment of fractures called the volar lunate fragment, which is a very special subset of fractures. Don't go by the size of the fragment. This is a very small fragment and it looks like it's very innocuous, but it gives attachment to some very important volar ligaments and it's a very unstable fracture. So for this you need a separate sort of, I'm sorry, this is being cut off by my own sort of visual here, but you can see this is the small size of the fragment, but don't be misled by the size of the fragment. It's a very important thing. So for this, because it is on the ulnar side of the wrist, you need a separate incision, not a volar Henle. This is called a volar ulnar approach to the wrist. This is the ulnar artery pulsation. You go straight, instead of reflecting the PQ on the radial side, you reflect it on the ulnar side. Otherwise, everything is the same, nothing complicated. You use a fragment specific implant. In this case, there's a special plate available. Sorry. This is called a ulnar hook plate for the volar lunate fossa fragment. This only holds this fragment. So this is a special implant and this is the plate. Simple. The plate is very simple. Just for this particular fracture, this is a fracture specific implant. Okay. So last but not the least, I'm coming to the end of my talk. There's something called a fragment specific fixation which came from a separate classification called the fragment specific classification, which was given in 1998 by Medoff et al. What they said is, when a fracture of the distal radius intra-articular happens, it happens in a particular way. Like these are the fragments, one dorsal, one volar, one radial and one ulnar. So these are the corners. So based on this, they said we have to have separate implants to hold each of the fractures because one plate cannot fix all the fractures. Okay, that was the philosophy. So the philosophy is that the plate should be separate for all the fragments, very low profile, and should have a spring-like buttress effect. It cannot be very bulky because we are putting more than one plate. It has to be very thin, but it has to be strong enough to allow early mobilization. That is the principle of this. And based on this, many plates have come into vogue. I'll show you a couple of case examples. This is a very comminuted fracture dorsal, and here and see this is the dorsal end. So this will not do well with the volar plating because if I put a volar plate here, the screws will just push these fragments away. So this needs a separate dorsal plate and a dorsal approach. So this is one example. So dorsal approach, 2 plates, and this has been done. And this is the follow-up of that case. This is another patient with the dorsal plate and a radial styloid plate. So these are all fragment specific plates which are now used for these specific indications. Last but not the least, you can use arthroscopy to just see the accuracy of your reduction, because if you are not very sure whether the articular reduction is good, some people use it, some people say no, but for something like a styloid fracture like this, a large fragment, you can percutaneously put the styloid, but you're not sure. You can actually manipulate the fragment with intraarticularly with a K-wire and then do the reduction and then pass the implant under arthroscopic vision. That way you are sure that your articular surface has been restored nicely. So you can use this as a valuable adjunct to your fracture fixation. So in conclusion, awareness is key. High index of suspicion, and then your intervention always has to be timely and appropriate based on the fracture. Okay. Last but not least, just going back here, don't think that the panacea for all distal radius is a locking plate. I don't want you to go back, because what they say is if you have a hammer in your hand, everything looks like a nail. And PG trainees are at their most dangerous once they go back from a conference or a meeting like this, because everything like they think they want to fix the very next day. So Not all nails are the same. So you should choose your hammer wisely. Use your common sense. Okay. Thank you very much. So if they have any questions, I'll take that. Otherwise, I'll go to my next topic.
Last talk, any questions? Any online questions?
The questions are coming a bit late. For Dr. Bedi said that it came in after.
So I'll take it at yes, yes, yes. I'll continue with tendinopathies of the upper limb. Thank you for bearing with me. I know it's a Saturday evening and probably many of you have better things to do, but thank you for being here and sitting through this. Okay, so tendinopathy again is a very common condition. You will encounter this every day in your day-to-day practice. In fact, you will see more of this than fractures when you start practice, because only the chronic conditions will come to you. Fractures will probably go to someone more senior because they know that they have to get operated. So this will be the bread and butter of your practice. So it is very important to have a very good working knowledge of this tendinopathy. And that is one good reason why you should pay attention for the next few minutes to what I'm going to say just now, because it's going to have a serious impact and a beneficial impact, on your day-to-day orthopedic practice. Okay. Not much importance is given in the orthopedic curriculum because we have much more important things to cover in 3 years. But then once you're practicing, you feel, oh, nobody has taught me how to manage a tennis elbow properly, or what do I do for a trigger finger. Okay, so these are the things you need to know, and hopefully at the end of this talk, you will have the answers. So a little bit about basic science and the etiology of tendinopathy. So it is basically caused by a tensile overload of the tendon, which can be internal due to degenerative conditions, or an external compression due to friction or pressure, or a combination of both. And you could get either an inflammation of the tendon sheath or a degeneration of the body of the tendon due to hypovascularity, or again a combination of both. So when we use the term tendinopathy, it's an umbrella term, but there are some specific terms which we use very casually, but it means something different. So tendinitis is specifically an inflammation of the tendon. Tenosynovitis is inflammation of the tendon sheath. Tendinosis is referred to chronic pathology if it is more than 3 months in duration. You don't say tendinosis in 2 weeks. Okay, it has to be definition wise at least 3 months. And the term tendinitis and tendinosis actually refer to histologic diagnosis. So histologic terms. So although we casually say tendinosis, it is actually a histological finding. You can't macroscopically say it is tendinosis. Okay, if you have to be very pedantic, these are the terms which you need to be a little bit careful. We use them very interchangeably, but at least we should know what they mean. Symptoms are very generic, pain, stiffness, loss of function, crepitus, muscle weakness, restriction of movement, various joints you could have in shoulder, elbow, or wrist. So I'll come to the specific tendinopathies later. So the common tendinopathies I'm going to talk about are rotator cuff, bicipital tendinitis, lateral and medial epicondylitis, tennis and golfer's elbow, decurvence, DQ tenosynovitis, ECU tendinopathy, and trigger finger. I think that will be enough for the common tendinopathies of upper limb. We'll leave out patellar and tendoachilles because it's lower limb. So tendinopathy could be due to extrinsic factors, due to the biomechanics or wrong training, for sportsmen. Sometimes drugs like fluoroquinolones may inhibit tenocyte metabolism, or you could get intrinsic factors like age and genetics. So older people have degenerative tears due to hypovascularity. Genetics, some people have particular type of anatomy of the acromion process called hook acromion type 2. So those people are more prone to impingement. So that is the genetic makeup which determines the type 2 hook-shaped acromion. So these are some genetic factors as well. Theories of causation, very briefly, I won't go into details, basic science. It could be mechanical, it could be a vascular due to poor vascularity, or neuro because of neurotransmitter signaling. So these are the 3 theories of causation of tendinopathies. Okay. And like bone healing, which happens in stages, tendon healing also happens in stages. You could have an intrinsic healing, which is similar to primary bone healing. And then you could have from the tenocytes and better biomechanics, and you could have an extrinsic bone healing with callus formation like you see in bone. So something like that, that is from invasion of the tenocytes on the synovium and the sheath. And this happens to contribute more by scar tissue rather than actual tenocyte. And the stages are again subdivided just like fractures. An acute stage, which is the inflammatory, then this is the first 48 hours, 24 to 48 hours. Then it is mainly the proliferative stage with various cellular cytokines. I'm not going into details. And then the remodeling, which goes on for from 12 weeks to up to a year. Okay. So these are the stages of tendon healing, and these are the factors at play, and this is the time frame. So this is acute inflammatory 48 hours, proliferative is maybe up to a couple of months, and then remodeling 12 months to 2 years. So it's just this, and these are the cells which are having a role in each stage of the tendon healing. So the histological appearance, see, if you see this is haphazard regenerating tendon, neovascularization here. This is normal tendon, wavy collagen bundles. So you have to remember that most of the tendinopathies, only inflammation is in the acute stage, okay? But once it is more than 48 hours, it is mainly degenerative, okay? So if you do a USG, you see thickening, calcification, small micro tears, neovascularization, etc. So nutraceuticals have been used extensively. You have seen every pharma company come up with some different product. Now there is a very good evidence for the role of them in the acute stage in tendinopathies. Type 1 collagen, mucopolysaccharide, vitamin C, plus other sort of nutraceutical drugs, amino acids in various combinations, turmeric, no turmeric, whatever. So the role of them is they promote collagen type 1 synthesis, which is the collagen bundles are made up of type 1 collagen. They avoid the bad type of collagen like type C collagen and aggregan. If they are formed, then the tendon is not strong. So type 1 collagen is what you need, and you need them in heavy bundles. And then these drugs have been shown to reduce pain, visual analog scale, etc. in clinical studies, improve healing, and not only in animal models but also in human studies. Now we'll talk about some specific tendon pathologies. Supraspinatus tendinitis, most common of the rotator cuff tendinopathies. It is the most affected. So you have the coracoacromial ligament and the subacromial bursa, and the pain is due to impingement. You have what is called the painful arc between 60 to 120 degree. What happens? Beneath the subacromial, in the subacromial space, the tendon of the supraspinatus and the biceps are most vulnerable to compression here when they pass here on the undersurface of the acromion. If the space is lesser because of a hoop-shaped acromion, I told you, so those people are more predisposed to impingement, and this is called the painful arc. So typically, when the patient moves the arm from about 30-40 degrees to 120 degrees, 60 to 120 is the most painful range. Beyond this, it's not painful. So 60 to 120 degrees, the inflamed tendon is pressing against the acromion in this arc of movement. So causative movements, causative could be repeated use of the arm to do any household activities, like you're doing some painting, suddenly you find that after 1 week of painting a wall or something in your house, some enthusiastic activity, your shoulder starts hurting. Or maybe occupational sports, badminton, overhead serving, tennis or something like that, okay? You could get these repetitive use. So treatment modalities, I won't go to the physiotherapy part. Any tendinopathy, acute stage, always rest, ice packs, NSAIDs, some friction massage, ultrasound, IFT. Then you educate the patient about activity modification, avoid the activities, overhead activities, and you want rest. You could use the nutraceutical tendon supplements to regenerate the tendon properly. And then the physiotherapy of isometric gentle loading, assisted activity, range of movement exercises, and the strength building. So arthroscopy has a role. This is the rotator cuff tendon, this is the humeral head, and this is where the tendinopathy occurs. You see this is normal, and then this is where it looks a bit wavy and irregular. And if the tendinopathy persists, you could develop small tears. You could have either bursal tears here, or you could have tears. If the tear progresses and it is symptomatic, it can be repaired arthroscopically. Okay. So next tendinopathy in the same region is bicipital tendinitis. It involves the long head of the biceps, which passes in the bicipital groove, and this is the same thing. Repeated irritation of the tendon causes inflammation, edema, and a microscopic tear with degenerative changes. Okay. So symptoms: patient will complain of arm pain here. It is again same, exacerbated by overhead activities or lifting weights. So there could be some confusion between SSP tendinitis and bicipital tendinitis. There could be a component of both. So you have to separately do tests to prove which is what. You could have an associated slap tear also. You know what a slap tear is? superior labrum anteroposterior, so slab tear in the shoulder, so that could be associated with the long head of biceps, tendinopathy. So you have to have a separate test for that. I'm going to talk only about bicipital tendinitis, not about rotator cuff. So suddenly in elderly patients or in bodybuilders who take steroids and do a lot of working out, they would suddenly come and say, doctor, I felt a pop and then a bulging in my arm. Very typically seen in elderly people also. That is one elderly subset, that is a degenerative tear and the bicep tendon ruptures proximally. In younger patients, mostly bodybuilders, weightlifters who take a lot of steroids for supplementing the anabolic muscle mass growth, they could have a sudden rupture of the biceps and they get what is called the Popeye sign. You know who Popeye was? Comic character with very bulky forearms. So similar like that. So this is the sort of analogy here. Popeye sign, sudden pop with a bulge in the upper arm, and clinically it looks like that. Long head of biceps is ruptured here and the muscle has contracted. So if it's a young patient, it is reattached. If it's an elderly patient, it doesn't cause too much of functional. If it's a degenerative person, 70s, 80s, you can leave it alone. Not a problem. Okay. So diagnosis clinically by speed test and Jorgensen test. Speed test is you ask the patient to keep the elbow extended and extend the elbow, flex the elbow against resistance. If the patient has pain here in the shoulder region, that is speed test. Jorgensen test, you have to remember the biceps is not only a flexor of the elbow, it's a powerful supinator of the flexed elbow. So keep the elbow in flexion and ask the patient to supinate against resistance. If the patient has pain over the long head of the biceps, that is Jorgensen test. So bicipital tendinitis 2 tests, speed test and Jorgensen test. You will be asked in the exam as a short note. Okay. Imaging, mostly X-ray will show nothing. So USG is very useful, and very rarely if you in doubt and the pathology has been persisting, to confirm the diagnosis, MRI is good. So basically what I'm trying to say is USG is a very useful investigation. It also happens the advantage of being a dynamic, but it is very observer dependent. So if there's a good sonologist, he can pick up a lot of pathology of the shoulder, on USG alone. You don't always need an MRI scan. And it is a dynamic thing. You can ask the patient to move the arm, see the position of impingement. All those things you will never be able to do in an MRI. So that way an MRI is inferior to a USG because it is not dynamic. Okay. So treatment, again, the tendinopathies, the treatment is almost the same. So I'm not going to go into the details. Rest, ice, NSAIDs, the same physiotherapy. Sometimes you could do for an arthroscopic decompression or an acromioplasty. So this is a arthroscopic decompression. And for chronic tears, you could do a tenodesis or a tenotomy, okay, a repair. So that's bicipital tendinitis in a nutshell. So we'll go into the next bugbear, which is tennis elbow, or also called lateral epicondylitis. Contrary to the name, it is not common in tennis players. It is more often seen in sedentary middle-aged housewives who do a lot of cooking, repetitive movements, while cooking. So pain around the lateral aspect of the elbow, repetitive forearm pronation, supination. It is not an inflammatory process. So the name itself is a misnomer. The tendinopathy is only in the first 48 hours, and that is why a lot of sort of controversy about the role of steroids. Maybe very earlier on they might give some effect, but then long-term studies have shown that in chronic tendinopathies there is very limited role of steroids, because it's not a problem. It's a degenerative process. How is a degenerative process going to help? Your next question might be, if it is a non-inflammatory process, why is there pain? It is at a metabolic level, because substance P, glutamate, all these pain-producing chemicals in a chronic tendinopathy situation are localized in that region. Those are the pain medias which are causing the pain, not the inflammation. So if you did a histological study, you would see a microscopic tear of the ECRB tendon with neovascularization. That is the pathology of tennis elbow. It's a micro tear of the ECRB. And the microscopic findings would show angiofibroblastic hyperplasia. But time tested, because we don't have anything to offer, you have given the tennis elbow support, you have given UST, you have given NSAID, patient is coming week after week, doctor, pain is not reducing, doctor, pain is not reducing. You want to do something, you will think, okay, maybe steroids are the magic answer. But long-term steroids, long-term studies have proven that only in the acute inflammatory stage, stage, there is a limited role of steroids, because it is not a inflammatory condition. Okay. So what else can you do? You can try these. You can try PRP or autologous blood. All these things have been tried to improve the condition. Okay. So diagnosis is made by clinically. Cosen's test is positive. X-ray usually normal. You could get a little bit of calcification in the tendon in some cases. But then again, it's a clinical diagnosis. If it is in doubt, you can sometimes do an MRI. Differential diagnosis is radial tunnel syndrome, where the PIN is compressed in the supinator, but the pain is a little bit distal to the lateral epicondyle, at least 3-4 centimeter distal. That is the commonest differential diagnosis of a tennis elbow, a radial tunnel syndrome. Okay. Treatment again is the same. You could use a counter brace belt. You could use UST, stretching exercises, steroid or a PRP or an autologous blood. Your practice. There is some evidence to show that PRP is superior to placebo, but autologous blood is superior to PRP. That is what the current consensus is. And then surgery, very, very rarely in recalcitrant cases, symptoms beyond a year, then you might need to do an open surgery, mini open, debride the degenerative tissue and stitch it back, or you could do it arthroscopically as well. This is arthroscopic. This is the setup. So the posterior approach. This is the capital arm. This is the radial head. This is where the tear is. You debride it and it will heal by itself. Okay. Same counterpart on the medial side. Again, the name is a misnomer. It's a degenerative condition. It's called epicondylitis, which seems to suggest it's inflammatory, but it's not. It's on the flexor peroneal condyle. Again, overuse injury caused by valgus stress and repeated activities like throwing sports, lifting weights, playing golf, not hitting the ball properly. So again, diagnosis is by reverse Cousins test. X-ray is normal. MRI in rare cases when the diagnosis is in doubt. Treatment is the same. Again, stretching exercise, NSAIDs, ice, UST, IFT, laser, steroid injections or PRP. Take your pick. Okay. Very rarely surgery. These are very common conditions, but if you don't know how to diagnose them and treat them, and the most important thing is the patient has to be really patient. You have to say that activity modification is the best important, because these are all overuse injuries. So what is going to work is activity modification. The patient has to rest the elbow, otherwise it's not going to get better on its own. All the other treatments are adjuncts. Which brings me to the hand now. Decurvain stenosynovitis, named after a French surgeon called Swiss surgeon. It's from Switzerland, Fritz Decurvain. That's the condition which bears his surname. So it's pain on the radial side of the wrist, distal to the styloid, over the first extensor compartment. Again, it's an overuse injury, seen commonly in housewife. It is also called the young mommy syndrome. Pregnant women get this very often. Why? Because of progesterone and fluid retention in the last trimester of pregnancy, all the soft tissues swell up, including the tendons. They'll have a little bit of added bulk. Now, if there is a tight tendon sheath plus overuse, why? Because they've never been used to it. Suddenly, after 9 months of having a baby in the tummy, they are holding the baby like this all the time. And this, a baby is a 24-hour job. Trust me, if you've seen anyone in your family, a young mother especially, it's a 24/7 job. So basically no rest at all. So constant overuse, they give this. But the treatment, it's always self-limiting. You never try and do surgery in, young mothers with decurvains. You just give them a brace. The problem is you can't give them NSAIDs because they're breastfeeding. But rest, ice pack, conservating, it settles down most of the time. So sometimes hypothyroid, the same reason for bulkiness of the tendon is an association. So diagnosis is by tenderness over the first extensor compartment. You all know about Finkelstein test. You know about Finkelstein test? The original Finkelstein test was, you do it actually in 3 stages. You get the patient to hang the wrist outside, and if gravity itself brings the pain, then you don't need to forcibly do this because it's more kind to the patient. If in acute stage, even just the very act of hanging the wrist off the table, the weight of the wrist will cause enough ulnar deviation to cause a positive sign. If that doesn't happen, gently get the patient to bend the wrist, and if that recreates the pain, that is stage 2 of the Finkelstein. That is good enough. Only rarely would you have to curl the wrist and do a passive kind of stretching, forcible stretch, which the actual Finkelstein test is, but that is very painful. At no cost you want to cause more pain to a already painful condition. The other way is a patient-driven test. You haven't heard of this. Please listen to this carefully. I know it's a long day, but this test I want you to understand and take home with you. It's very interesting. I didn't know about it until I started doing hand surgery. So this is called the WHAT test, W-H-A-T. And WHAT is an acronym which stands for wrist hyperflexion, abduction of the thumb. So what it means is, this is a patient-driven test. Ask the patient to bend the wrist, he'll have no problem in a DQ. Ask the patient to abduct the thumb, you just place your finger here. The moment he's abducting the thumb, He will himself have pain and stop at the point where he has the pain. Because it is a patient-driven test, it is much more friendlier to elicit rather than a very crude DQ, which is forcible manipulation by the patient, and you have the patient screaming. And whenever you're examining a patient, if you've worked, in the US and the NHS, any other system apart from India, they will attach a lot of importance to this. The very act of building a rapport with the patient is on how gentle the doctor is with the patient. And just by doing a clinical test which increases the pain suddenly, that trust starts, going away very quickly out of the window. So you have to be very careful not to cause excessive pain to the patient. So what test is very useful? X-ray again in DQ is going to be normal. It's a tendinopathy. X-ray will be normal. USG is again very useful. You could see this thickened tendons. Sometimes it is important because the APL and the EP could be in separate sort of compartments. In 20% of the cases, they are in separate compartments. So sometimes when you give an injection of cortisone and you think the steroid injection is not working, it may be that the steroid has gone into this compartment and APL has been sort of affected favorably, but the drug hasn't reached the deeper compartment because it's in a separate subsheath. So that might be one of the cases for steroid failure in DQ. Okay. Because in DQ veins it is not a tendinopathy, it is more of a tenosynovitis. So the inflammatory component is more. So here there is a greater role for steroid injection. Okay, you understand. So here MRI we rarely do. For DQ it's a clinical diagnosis, but this is just from the internet. I have never done. So you see this thickening around the first compartment tendon. So this fluid here. So again, that is DQ. How do you treat it? You can give injection very rarely, first compartment release, if you have tried it for at least 6 months and the pain is not getting better. Okay. I'll talk a little bit about ECU tendinopathy and trigger finger. You guys have a long day, but I have to complete my quota of talks. Okay. So ECU tendinopathy, again, very easy. You all know about golfers, but not many of you read about this, but you get this very commonly. Okay. ECU tendinopathy is on the ulnar side of the wrist here. Extensor carpi ulnaris tendinopathy. You see, normally in the distal ulna, there is a groove here. And this is where the tendon passes. Like this. This is the surface marking of the tendon. And if you look at it in cross section like this, the tendon goes like this, and there is a separate subsheath which covers the tendon and keeps it in place. So this is the normal anatomy of the ECU tendon and its subsheath. So in ECU tendinopathy, there is dorso-ulnar wrist pain with repetitive wrist movement. Again, common in players and sports persons, etc. And how do you check it? You ask the patient to dorsiflex and ulnar deviate the wrist against resistance, the patient will have pain over that region. Now, MRI might sometimes be required. You don't know whether it's a TFCC tear or whether it's a ECU tendinopathy. Here you will see, this is a normal tendon here. You see these, I have color marked the extensor compartment, first compartment, second compartment, third, fourth, fifth, sixth. This is the sixth here. And here look at it in a pathological situation. Same compartment, these are the normal fluid signals around the sheath. But look at this one, this is lighting up like a Christmas tree. So this is ECU tendinopathy, a lot of fluid around the tendon, okay. So treatment again initially with the long forearm brace, rest, ice, splints, etc. You could try very careful steroid injections. If it doesn't work, you can debride the tendon sheath. Just like a DQ release, you can release the tendon sheath and very carefully remove all the tenosynovium around it and then suture it back. There is another condition very interesting in ECU tendinopathy called a snapping or subluxing ECU tendinopathy. Look at this video. So normally it's like this. This is in a separate subsheath. This is the normal subsheath. This is the cross section. Now what happens is, if this ruptures for some reason, the tendon comes out and then goes back. With every pronation and supination, the ECU tendon comes out of the subsheath, subluxes outside and inwards, outside and inwards. So that leads to a snapping sensation with pronation and supination. Look at this video here. Can you see? So usually there's a clicking sensation with, you can see the tendon coming in and moving out. So this is a subluxing ECU. It's a simple surgery. You just sort of debride the tendon, find out the tendon sheath and do a double breasting and repair it back with sutures, vicryl sutures. Just double breasting of the tendon sheath, because it becomes lax. You just have to incise it, put the tendon back into its groove, get the sheath to close over tightly, and that's it. Simple surgery, okay? So, but you have to know the pathology, only then you will be able to treat it. Huh? So, which brings me to the last topic, another 2 minutes and I'll spare you the agony. So trigger finger, very common, again, very, very common. You get this in your clinic. This is because of a catching sensation in your finger. Suddenly it locks like this, and then when the finger is locked, the patient can't straighten it. It bends and straightens with a catch every time, like a trigger. So this is due to a size mismatch between the pulley system of the flexor tendon and the size of the tendon passing through it, because of it. So if I am a size 42 and I'm wearing a size 40 shirt, obviously I'm going to feel tight. So it's somewhat like that. The tendon is my human body. My shirt is one size smaller. I'm feeling tight. I cannot move comfortably. Okay. So look at this video again. You see this tendon, if it is thickened, and this is the pulley here, it is not gliding properly because of the thickened pulley. So this starts getting inflamed, and this thickened tendon can no longer pass through a tight pulley. So this is how this tendon triggering happens. So every time this thickened tendon has to pass through this tight pulley, there's a catching sensation. So tendon catches on the A1 pulley, which bends with a catch. So you look at this. This is a trigger thumb. One of my patients, it clicks. See, click. Again clicking. So this is a very common condition. It may be painful, associated with a few conditions like hypothyroidism, diabetics, and rheumatoid. You can have in multiple fingers in diabetic and rheumatoid patients. More than one finger, maybe bilateral. So diagnosis again, tenderness over the A1 pulley, painful triggering. X-ray will be normal. All tendinopathies you see, very rarely you will get any X-ray findings. But you could do a USG. Again, it's a dynamic test. If you put your probe on the A1 pulley and see the tendon moving, you can see that it is catching every time there. Okay. So that's the USG finding. Very rarely you do an MRI. You never do an MRI for simple condition like this. Okay. I just put it in just for completeness sake. Okay. Management again, very simple. In the early stages, you do a contrast bath, alternate hot and cold compress. So couple of minutes in warm water, 1 minute in cold water, warm water, warm, cold for 10 minutes. That reduces the swelling, and then you get them to move with a sponge ball or a gel ball like this. So that in early stages, if it's only a few weeks pathology, it will get better. If it doesn't, you could try a very careful injection into the tendon sheath. You have to mark out the A1 pulley and pass the needle in such a way so that infiltrate only the tendon sheath. Be careful not to penetrate the tendon, because you could damage or rupture the tendon with a steroid shot if you're not careful. So it needs a bit of experience. A slight give way of sensation of the needle, it tells you that you're exactly in the tendon sheath. Inject just 0.5 ml of the steroid, that should be enough. And very rarely, if that doesn't improve, then you could do an open release of the A1 pulley. It's a simple surgery which you can do in 5-10 minutes in local anesthesia, but that solves the problem once and for all. So lastly, the tendinopathies, you have to be aware of the anatomy, you have to aware of the pathology, and you have to know the clinical test to pick up the individual tendinopathies. Early diagnosis and judicious investigation. Don't ask for an MRI where a simple clinical test will do. Be judicious in your use of investigation. Don't ask for an unnecessary X-ray. Go for a USG, because that will give you more information. So you have to be judicious in your choice of investigation. Most of them respond to conservative treatment. You have to remember, surgery only when conservative management fails. Okay. Thank you very much for your patient writing. I know it's been a long day. I'll be happy to take any questions.
So, Ravi, there is one question online, which is while we are setting up. Yeah. So, can you say something about ganglion? We just set up here. Set up the
ganglion is a completely different entity. It's degenerative. So, ganglion is myxomatous degeneration of the synovial sheath of a tendon or joint. So, normally in the hand scenario, we encounter it in 3 situations. You have something called the dorsal ganglion. So the thing about dorsal ganglions is it may be very innocuous and they don't grow in size, and they're not symptomatic apart from the cosmesis aspect. USG is usually enough to diagnose. But then the important thing is most of them have a communication with the scapholunate ligament. So initially, if they are asymptomatic and small in size, we just ask them to observe. We discourage any sort of injections or steroids or anything. Most of them may vary in size and may settle down. Only if they grow bigger and bigger and are symptomatic, then we advise surgical excision. Again, can be done arthroscopically. But the important thing is there is a valvular connection with the joint, at the level of the scapholunate ligament. Unless you go all the way to where the joint origin connection is and you ligate that or tie that off, it is bound to recur. It's almost like if you don't excise it completely with the connection with the joint, if it's not dealt with, there's almost a 15 to 20% chance of recurrence. This is for dorsal ganglion. For volar ganglion, you have to be very careful because this is very close to the radial artery. So before you attempt any surgery on the volar ganglion cyst, you have to do what is called the Allen's test and check the patency of the ulnar artery. Only then you are careful that even if inadvertently, if you cause any damage to the radial artery, at least your ulnar artery is secure. Huh? So once you have ensured that, if you're a little bit careful, you use loop magnification and then it's just simple dissection. Bible treatment is as old as the Bible itself, but it is frowned upon nowadays. You're just giving paracetamol for fever without treating it, whether it's malaria or typhoid or, so symptoms will be good, but it is going to come back at some point of time. The adhesions will reform, will come back. You can try that. It's not a permanent treatment. So only, see, the best thing is if it's not causing any problem, do a USG to establish it's a ganglion, leave it alone. I would tell most of my patients, they are reassured that it's not a tumor, it's not malignant. They're quite happy to leave it alone. That reassurance itself is enough. I tell them come back only after you, like you said, the patient has to earn the ganglion surgery. I won't operate easily.
Okay, thank you, Ravi. Yes.
As you mentioned in the beginning of the research, the role of substance so indication is common. So neural pain is related in this.
Frozen shoulder is again a different kind of entity. So you have a capsular sort of adhesion. So I couldn't understand your question. So in this tendinopathy, substance P. Yes, there is a role of septum P and local chemical mediators of the pain. That is why one of the treatment modalities, I couldn't go into the details, but they use nitric oxide like they use for patches for transdermal glycerin patches. So nitric oxide and these agents have been used, transdermal GTN patches have been used for pain relief. And the mechanism is like this: they cause a vasodilatation, they cause neovascularization, more blood flow, and that is why they wash away the substance P and the chemical mediators, and that's how they produce the pain relief. Very difficult to cover everything in half an hour, but anyway, that's done. Next.
Okay, so we'll just talk about a few topics which we think will be useful for the PGTs. One is about the fractured tibia. Okay, so in anatomy, in MBBS, we have learned that you divide all the long bones into proximal, middle, and distal thirds. But in traumatology, we tend to talk about more about proximal component. Now, what does this term mean? So, proximal is a part of the body which is closer to the center of the body and relative to another part, and distal is the reverse. But when we are talking about traumatology, what we are discussing really is this square, Heim's square, where you are looking at a square. Do you have this thing? Oh, we are blocking that. Yeah. Fortunately, this is being blocked, so I can't show it here. Anyway, so this is a square. Can you move it that side? Or maybe down below. So we're really talking about a square where you have where the length and the breadth of the part is equal. Okay, and when we are looking at proximal and distal fractures, we have actually, these fractures are actually very similar on four components. One is that both of these injuries have serious soft tissue components. Both of these injuries can involve the joint. In other words, you could have an intra-articular component. Most of these injuries can have a serious vascular injury, and both of these injuries may need to be treated in two parts. Okay, so you can see here the Heim square. I've marked out the square here, the proximal and the distal. And as you know, the bone can be divided into epiphysis, metaphysis, diaphysis. And these parts actually demarcate the bone.
21.
Now, these two fractures are misunderstood fractures. Why? Because in traumatology, we normally talk about reduction of the fracture, we talk about retaining the fracture, and we talk about rehabilitation. Now, in reduction, you have to reverse the insult to the fracture. So if you have impaction, you disimpact it. If you have radial displacement, you do ulnar displacement. If you have pronation, you do supination. And then you have, once you have reduced the fracture, you have to retain it in some form, either with a POP, a nail, a plate, screws, whatever. And finally, you have to rehabilitate the patient with physiotherapy and increase of range of movement. Now, when you're treating proximal and distal fractures, this protocol can slightly fail because this protocol is mostly based on anatomy and not physiology. It does not factor in vascularity, it does not factor in soft tissue injuries, it does not factor in skin and muscle problems, it doesn't factor in degloving injuries. And remember, an X-ray is just a 2D presentation of a 3D problem. So you have these classical degloving injuries. These are fairly easy to diagnose. But what is difficult to diagnose are the subtle ones. Now this one is also not that subtle. You can make out that this is very badly injured. This is one of my patients from my nursing home, and you can see the degree of blistering. But sometimes and this patient we treated in 2 stages, and you can see at the end of 2 months, the vascularity settled down, the wound is soaked well and it has healed quite well. So you can see that we have been able to reverse the injury. But sometimes these injuries are not so subtle. You might have subtle blistering on the top of the fracture, like here or here. Now these are, if you don't assess these injuries properly and you go in and you stick your knife into it, you're going to have a non-healing wound, you're going to have an infection, you're going to have a lot of problems. So it is very, very important that you assess these injuries properly so that you don't have a catastrophe. So here are some more injuries. You can see here more subtle injuries. And when you are looking at the X-ray, you are only seeing the bony components. So you're seeing the bony parts, the fibula, the tibia, the tibial plafond. But if you dig deeper and you do a 3D image, then you will see that the injury is much more complex than what you saw initially. So this is a 3D of around the knee, and you can see here that the injury is